Peptic ulcer disease. A break or ulceration in mucosal lining, stomach or proximal duodenum, single, multiple, acute or chronic. Superficial are called erosions. Ulcers extend through muscularis mucosa and damage blood vessels. They rarely perforate the GI wall. Duodenum is the most common. There's an inflammatory cytokine release. Cushing ulcer is associated with brain trauma. Risk factors: chronic NSAID use, alcohol, smoking, advanced age, chronic disease, type O blood products, Zollinger-Ellison syndrome, stress, trauma. Gastric ulcers are the same prevalence in male and female, generally between 55 and 60 years old. And chronic gastritis is a huge risk factor. Pathogens would be H. pylori and NSAIDs. Clinical manifestations: chronic intermittent pain, 2 to 3 hours after eating, pain in the middle of the night that's gone in the morning, pain relieved by food and antacids, hemorrhage. This is the number one cause of mortality. Hematemesis, melena, sudden severe abdominal pain. And then for gastric, it's pain in the upper abdomen immediately after eating, relieved by antacids. Ulcerative colitis, chronic inflammation causing ulcerations of colonic mucosa, most common in rectum and sigmoid. Inflammation at the base of crypt of Lieberkulm in large intestine, begins at the rectum and extends. Mucosal inflamed and small erosions form ulcers. Abscess, necrosis. Risk factors: susceptible individuals between 20 and 40, less common in people who smoke. Clinical manifestations: bleeding, cramping, urge to defecate, frequent diarrhea with small amounts of blood and purulent mucus, increased volumes of watery diarrhea, intermittent periods of remission and exacerbation, increased pulse rate, dehydration, weight loss, anemia, fever from dehydration, anal fissures, hemorrhoids, and rectal abscess. Diagnosis: history of symptoms, endoscopy, biopsy, stool culture. Treatment: mild to moderate, is treated with 5-aminosalicylate therapy and then steroids. Severe disease: immunomodulatory agents, TPM for extreme malnutrition, surgical resection of colon, proctocolectomy with ileostomy or ileorectal anastomoses, ileal pouch, anal anastomoses. Crohn's disease. Affects the GI from mouth to anus, distal small and proximal large intestine is most involved. Ulcerations can produce fissures. Typical lesions is a granuloma. Fistulate may form in perineal area, may develop strictures. Risk factors: smoking, decreased fiber, increased carbohydrates, NSAIDs, altered intestinal microbiome. Smoking increases the risk of severe disease and may cause a poor response to treatment. The pathology is inflammation begins in later intestinal submucosa and spreads. Skip lesions can involve any part of the GI tract. Clinical manifestations: diarrhea, rectal bleeding, weight loss, abdominal pain, anemia related to absorption of B12, hypoalbuminemia, intestinal complications. Diagnosed with small bowel imaging. Treatment is to stop smoking, steroids, immunomodulators, anti-tumor necrosis factor, anti-inflammatory, and surgery to manage complications. Celiac disease. Autoimmune consumption of gluten results in damage of the small intestine, affects 1 in 100. Risk factors: family history, Down syndrome, Williams syndrome, diabetes type 1, and it's common between ages 10 to 40 to start getting the disease process. Clinical manifestations: diarrhea, gas, bloating, poor appetite, skin rashes, fatigue, anemia, and headache. The treatment is decreased gluten products, wheat, rye, and barley. Cirrhosis. Acute is usually mild and resolves spontaneously. 20% becomes severely acute. Obstruction to outflow of pancreatic enzymes, direct cellular injury from ETOH, autodigestion of cells cause inflammation, vascular damage, coag necrosis, fat necrosis, and pseudocysts. Edema causes ischemia, pro-inflammatory cytokines in blood. Risk factors: gallstones, alcohol, drugs, viral infection. It has a high risk of mortality. Chronic is associated with alcohol abuse. Bile or pathogens are bile, pancreatic duct obstruction, pancreatic cells metabolize alcohol causing toxins. Protein plugs are related to alcohol. Spasms in the sphincter of Oddi and obstruction are related to alcohol. Chronic necrotic cysts and necrotic debris. Clinical manifestations: vasodilation, hypotension, shock, ARDS, heart failure, coagulopathies, intra-abdominal hypotension, SIRS, paralytic ileus, GI bleed, peritonitis, sepsis, pancreatic fibrosis, strictures, duct obstruction, epigastric mid-abdominal pain. Pain may radiate to the back, nausea, vomiting, jaundice, abdominal distension, hypocalcemia from calcium deposits, hypercalcemia from damage to the alpha cells. Diagnosis is fever, leukocytosis, labs imaging, increased serum amylase. Doesn't have to have it, but it can. And the number one sign is increased serum lipase. Treatment is narcotics for the pain and pancreatic secretion, and to decrease pancreatic secretions, that's rest of the gland, NPO, NG tube to low wall suction, J tube, stage 2 receptor antagonists, and antibiotics. Chronic liver disease or cirrhosis. It's irreversible, 25% mortality rate. release of inflammatory mediators, chaotic fibrosis, biliary channel obstruction. Alcohol fatty liver is the mildest, and you can get it with small amounts of alcohol. Alcoholic steatohepatitis is a precursor to cirrhosis. Increase stimulants, it increases the stimulates. Let me try this again. It increases this stimulates of irreversible fibrosis with inflammation and necrosis. Alcohol is transformed to acetaldehyde, which alters the hepatocyte function. Risk factors: Hep B and C, alcohol, fatty liver, autoimmune disorders, alpha antitrypsin deficiency, hemochromatosis, Wilson disease, glycogen or lipid storage disease, drugs, toxins, hepatic venous outflow obstruction, right heart failure, and alcoholic steatohepatitis. Pathogens are Hep B and C, alcohol, non-alcohol fatty liver, Kupffer cell and macrophage activation promotes inflammation. Clinical manifestations: jaundice, portal hypertension, new vascular channels cause shunting of blood from the liver. Regeneration process is disrupted by hypoxia. The liver is got a cobbly appearance. The liver size either increases or decreases. Anorexia, nausea, edema, hepatomegaly, splenomegaly, decreased libido, and renal failure. The alcoholic liver is, of course, from ETOH abuse, coexisting liver disease. Alcohol is most prevalent in cirrhosis, and 25% of alcoholics get cirrhosis. Portal hypertension, increased blood pressure in the portal venous system, resistance to blood flow. Normal pressure is 3 millimeters, and the portal hypertension increase is equal to or greater than 10. Varices are collateral veins with prolonged pressure. Mortality from varice rupture is 30 to 60%. Pathogenesis is caused by disorders that obstruct blood flow. Intrahepatic shunts, thrombosis, inflammation, fibrosis of the sinusoids, biliary cirrhosis, viral hepatitis, parasitic infection, hepatic vein thrombosis. The most common is fibrosis and obstruction from cirrhosis. Clinical manifestations: varices, splenomegaly, ascites, hepatic encephalopathy, hepatopulmonary syndrome, bloody emesis, melena, rupture of varices, hematochezia with large rectal bleeding. Diagnosis is with an upper GI endoscopy and an eval of the portal venous pressure. Treatment is non-selective beta blockers. Stop any bleeding using vasopressors and compression. A TIPS procedure. Anastomosis of the portal vein. Hepatic encephalopathy. Complex neurological syndrome. Rapid after acute hepatitis. Slow during cirrhosis. Portal hypertension after portal systemic bypass or shunting. Toxins circulate freely in the brain. Pathogenesis, collateral vessels shunt blood, allowing the toxins from the liver to get into the circulation. Most common is ammonia. Clinical manifestations, impaired behavior, impaired cognitive and motor function, cerebral edema, infection, hemorrhage, electrolyte imbalance, including zinc, constipation, memory loss, irritability, disinhibition, lethargy, sleep disturbances, a flapping tremor of the hands, which is asterexis, slow speech, bradykinesia, stupor, convulsions, and coma. Diagnosis is history and a psychometric test, electroencephalography, There we go. And then check blood work, and you're looking for an increased serum ammonia. Treatment is correction of fluid and electrolyte imbalances, withdrawal of any depressant drugs, dietary protein to decrease ammonia levels, lactulose to prevent ammonia absorption in the colon, neomycin, but that can be nephrotoxic, glutaminase inhibitors, rifaximin decreases the production of ammonia, and extracorporeal liver support.